I think that there is always a conclusion. We have to wrap up, and it's time to make some consideration also in looking at all the things that has been said during these 2 days. We had a sort of leitmotif, a fil rouge, a thread, that was indeed the idea that we have to target our intervention on a specific patients. But the problem is that we cannot translate into simplicity a complex phenomenon. Complexity is complexity. It's the way in which the nature acts. That's a complexity. And the problem is that as soon as you look at the ARDS, has been said several times, you are speaking about a syndrome. And then you have several phenotypes. And these phenotypes do have different treatable characteristics. And we have the need of identifying them somehow. And the other problem that we cannot apply the same principle to all. One size doesn't fit all. And we know that very well. Maybe this is the reason why, looking at the report of the LungSafe study, the epidemiology tells us that we are relatively poor identifying the ARDS. And the capability of recognizing ARDS ranged at something like 50% for the milder cases, and we are slightly better for the more severe ones. But still, we are incapable to recognize promptly and identifying with the right way the situation. I take the advantage of illustrating one of the table of this review that has been recently published, that in my opinion is a very good summary of what has been said over these 2 days. The table is divided into 4 columns. The first is related to the lung injury mechanism. The second is the clinical response. The third is the potential tools and monitoring. And finally, the potential future research. And if you look to the traditional form of the ventilator lung injury, because we have to keep in mind that our main principle is not to harm, and we traditionally look at what has been called the volotrauma, in other words, the alveolar overdistension, we know that what we can do is just to reduce the tidal volume, to reduce the P-plat, the plateau pressure, and put the patient prone. And if you look at the potential tools and monitorings that we have analyzed several times during these 2 days, there's the ventilator settings and waveforms to look at. There is the esophageal manometry that can help us identifying the transmural pressure and the transpulmonary pressure, and the stress index, which is a very rough way, a very rapid way to identify if ventilating in a control mode our patients are theoretically in a safety range or not. And if you look at the other phase of the coin, which is represented by the atelic trauma with the lung inhomogeneity, what can we do? Increase the PEEP, prone positioning. Someone may propose the recruitment maneuver. And again, which are the tools that we can exploit in order to identify the situation? The CT scan, the PET, which is something very fashionable but not very easy to be performed, and EIT that is expanding more and more the possibilities under our eyes, and the lung ultrasound. Each of these different techniques do have limitations. But notwithstanding that, our knowledge is improving gradually and probably will help us in better categorizing our patients. And we spoke also several times about the driving pressure, which is indeed a function of the tidal volume and the compliance of the respiratory system, and just targeting our intervention, looking at this may be the real option. When this is not enough, we do have other possibilities for the future to be validated and investigated even more, which is the extracorporeal CO2 removal, the ECMO, and the possibility of minimizing the injuries that are imposed by the mechanical ventilation. Then there are other potential forms of lung injury. Look at the ergotrauma. Luciano Gattinoni has spoken about the power, the mechanical power. Mechanical power, in substance, tells us that you have to take into account several variables: the volume, the pressure, the respiratory rate, and the flow that is often forgotten. And in this case, what can we do to reduce what is called the ergotrauma? Tidal volume, we can reduce the respiratory rate, we can reduce PEEP, adapting to that given patient. And then, if we want to monitor that, the possibility that we have in our hands are represented by the ventilator settings and the waveforms. However, we always have the possibility to combine in the future various opportunities, such as the possibility of reducing the mechanical power insult using the extracorporeal support. Very low tidal volume, low respiratory rate, and extracorporeal CO2 removal, for example. And you know that there are a number of studies that are just focusing on this specific aspect. Then the other problem that has been alluded to several times is the myotrauma, which is represented by the situation where the diaphragmatic injury represents a major issue. And again, what we can do is just to titrate our ventilatory inspiratory support. We can titrate and target it better the sedation, and we can explore the real loading of the diaphragm. We can again use the ultrasound that has been illustrated this morning so beautifully, the esophageal manometry, which is several times analyzed, or the P01. And then it is our aim to find out for the future a protective mechanical ventilation strategies for the diaphragm. Has been spoken about the self-inflicted lung injury. Despite personal convincement, I, to be honest, don't rely upon this concept that much, because indeed it's something that, in my opinion, should be anti-physiological. But said that, we can interact on this concept through the deep sedation and neuromuscular blockade. Again, the manometry, and the possibility of evaluating and helping the spontaneous breathing in the right way. Finally, several times, and also in the workstations, has been mentioned the patient ventilator dysynchrony. And this implies a number of possible variables can be manipulated at the bedside, changing the tidal volume, increasing the expiry time, anticipating the expiratory trigger, decrease the trigger sensitivity, manipulated sedations. And again, our monitoring is represented by the waveforms, the esophageal manometry, and so on. And for the future, we need to evaluate other possibilities that in a sophisticated way just can better synchronize the mechanical ventilator to the neural drive, such as the NAVA, for example. But this just to recapitulate altogether the various things that we have analyzed during this today. This is my conclusive slide, because at the end, as I mentioned during my case report study that I just showed you yesterday, this review proposes an algorithm of intervention. It is a very clinical one, but very reasonable. I don't want to go into the detail of that, but it opens several possibilities, since the milder form up to the most severe ones, just according to the suggestions of the new definition of the RDS, where there was an allocation of the various therapeutic resources depending upon the severity of the RDS. I strongly invite you to read these reviews and at least make a reflection of these opportunities and this algorithm that is very reasonable from the clinical point of view, but obviously This is not the gospel. It's just an indication. It's just a suggestion. With this, I conclude my presentation, and I strongly hope that you enjoy these 2 days with us.